Thank you, professors. I'm a PhD student in biotechnology, and I also would like to thank the scientific committees for this wonderful opportunity to present some of the results of my PhD. So first, let's see why cerebral perfusion is a key parameter to consider in order to prevent postoperative complications and reduce hospital costs. So 7 million of patients undergo general anesthesia every year only in France, and 40% of them are over 60 years old. And 5 years ago, a randomized controlled trial was conducted among this category of elderly people. In the group where hemodynamic optimization was performed to keep blood pressure at a higher level, the risk of postoperative neurological and renal dysfunction was reduced. So with this data, it appears that millions of patients worldwide would potentially benefit from personalized brain perfusion optimization. So EEG is a good candidate for brain perfusion monitoring because it is already widely available in the operating room to monitor sedation level. It has also a very stable signal that reflects directly brain function. So the challenge here is to repurpose raw EEG data routinely collected in the OR for monitoring cerebral perfusion level. Before going any further, I would like to expose you two very important postulates. The first postulate is that cerebral autoregulation thresholds vary widely. As you know, there is protective mechanism in main organs called blood flow autoregulation, and as we see on this graph, thanks to an active microvascular component, cerebral blood flow is maintained constant for a certain range of blood pressure. So blood pressure is not correlated to arterial pressure when, blood flow is not correlated to arterial pressure when autoregulation is efficient. However, vascular tone adaptation is limited by numerous factors, and at some point, some correlation appears between blood pressure and cerebral blood flow, and every change in blood pressure is impacted on cerebral blood flow. And the second postulate, as we see on the right panel, is that cerebral blood flow is reflected on the Fourier transform analysis of EEG signal. So we see that impairment of cerebral blood flow is first characterized on EEG signal by loss of faster frequency, called alpha frequencies, and then increasing slower frequencies, called delta frequencies. So based on these two postulates, we published a pilot study on a cohort of 36 patients admitted for a neuroradiology procedure under general anesthesia. We created two groups based on the value of correlation coefficient between blood flow velocity collected by transcranial Doppler and mean arterial pressure, called the mean flow index. In fact, as we saw on postulate number 1, if cerebral autoregulation is efficient, there is no correlation between cerebral blood flow and arterial pressure, so the mean flow index would be inferior to 0.3. On the contrary, if autoregulation is impaired, there is high correlation between these two variables. So on the left box plot, we see that age is similar between groups, but that patients with poor autoregulation need more vasopressor support to maintain same blood pressure level. And interestingly, on Fourier transform analysis, on EEG signal, we see that patients with poor autoregulation have a slower dominant alpha frequency, which is called alpha peak frequency. And in multivariate analysis, the association between EEG signal and perfusion is independent of major confounding factors such as ASA score, vasopressor rate administration, and age. So this means that alpha peak frequency could be a good candidate biomarker to detect impaired brain perfusion. So at this point, we can sum up the result by saying, that there is a significant relationship between intraoperative EEG and perfusion assessed by the mean flow index. But the next step is to know if it is possible to optimize cerebral perfusion intraoperatively. And I also would say that, of course, this result must be tempered by some limitation. First, it's a pilot study, so it's a small cohort, and it concerns only one field of surgery, which is the neuroradiology procedure. So here is a little window on the next step of this research. So here we see mean arterial pressure and mean blood flow velocity time series on upper panels, and the percentage of delta and alpha frequency power of EEG signal during the same period of time. So these data are consistent with postulate number 2, which means that improvement of cerebral blood flow induced by hemodynamic optimization is characterized on EEG signals by an attenuation of slower frequencies and an increase in alpha frequency. So, of course, this is preliminary result here for only one patient, and we plan to extrapolate this result to a larger cohort of approximately 70 patients. So, as conclusion, I would like to thank all the people I'm collaborating with during this PhD, and that make this a wonderful journey, and thank you all for your attention.
We're open for questions. So what kind of montage, what's the placement of the leads on this? Is it standard, or is it, how many do you have to put on?
It's only frontal EEG, so it's only 4 electrodes.
Okay.
Yeah.
Yeah, putting on a real EEG is a total pain. It takes a long time and is not worth it, quite honestly. But if you can do it in 4, that's great. There's also a company called Forest. They make a hat that you put on. The advantage of it is it's all pre-specified leads, and they're using it for ambulance to identify people with large vessel occlusion. It's not a flow parameter analysis. It's strictly as one side of the brain having output that matches the other, and they have some AI analysis. But it's a similar technology that you might be able to copy. Because the hat makes it so simple. You put the hat on, it looks like a beanie, and it says, go to the hospital now,
Yes.
or go to the clinic.
Yeah,
But
yeah. The aim here is to make something very simple and very useful, so that's exactly that.
yeah, great. Anybody else? If not, then I think that's it, and we're going to turn this over to Dr.